thumbs up. So same for everybody. All right, give a few minutes.
Really like.
Everybody in here. All right. Well, so today we're going to start talking about, start really getting into some more of the peripheral stuff. So the stuff Jim sent out, I understand, was about heel pain and kind of some differential diagnosis components, some illness scripts and things of that nature, which is, you know, essentially I'm glad we're kind of into this stuff. This is more my domain. I really kind of spent much more time doing foot and ankle stuff early on before kind of getting forced into being a spine specialist. So this is really the stuff that I really learned real well early on. So if anybody has any specific questions about the presentations, let's get those out of the way now, and we can kind of see where that sort of stuff takes us. Nothing specific? All right, you guys are all experts already. Good to hear. All right, so when we're looking at heel pain, the first thing that we really have to kind of consider is the idea of a fracture, right? So there's kind of three methods that we can develop a fracture in the heel, in the calcaneus. First being the obvious one, which would be a true macro trauma. So that's an actual impact, something of that nature, to the actual calcaneus. It's most common with a fall from, you know, good height, landing on the foot. That's one of those things. I had a friend of mine that actually fractured his. He was riding a skateboard and the skateboard went out from under him, landed on his back, and then he whipped his heel down onto the ground, onto the pavement, and it fractured pretty good when that happened. So those are usually pretty obvious, and they're not typically going to be the type of people that'll end up coming into your clinic to see you right off the bat, because they're probably more than likely to going to be going to the emergency room to get imaging done. There is the possibility of something more subtle, you know, more of a hairline type fracture, things of that nature, that would be caused by the same sort of trauma. So that's a possibility. The other would be, one of the others would be a stress fracture. Jim usually suggests that this is due to substantial amount of exercise, typically some sort of high impact, repetitive high impact thing like running, like a heel runner, for instance, somebody that's doing, that has kind of altered their usual training regimen. So this is, you know, the person that's been a recreational runner. They run to stay in shape. They don't do it for competition, but they've decided at a certain point that they're going to go out and run a marathon, something like that. But typically you'll see this much more commonly with somebody that is actually a heel runner, where they actually strike the heel of their foot with their stride, as opposed to the more common midfoot or forefoot running. So that's something that we have to be aware of, is the kind of the activity leading up to the injury. Most stress fractures, in fact, this is very pathonomic of stress fractures, is they're going to be progressive. They're going to continue to worsen over time. And there's not going to be any specific trauma associated with those things. The other one, and this is more of a differential with a stress fracture, would be some sort of pathological fracture, right? So this is the type of fracture that'll occur with something like, you know, osteoporosis, Paget's disease, DISH, which is a diffuse idiopathic skeletal hypertrophy, which eventually starts to degrade. So those are some of these. You know, you could certainly have it with something where there is actually a tumor or maybe even a cyst within the bone that just weakens the cortical structure, and eventually the architecture fails, right? So That tends to be more differentiated with a stress fracture because they are progressive, but they can be more sudden as well, depending on the actual degradation of the bone around whatever the structural fault is with pathology. Okay, so once we've kind of ruled that out, the most effective way of ruling that out is actually with the calcaneal squeeze test. If you guys watch the video, Jim talks about it quite a bit. So basically what you do is you take the calcaneus and you just squeeze it in between your hands, looking for reproduction of pain. Now, that is not something that we should be doing if we have the suspicion of an overt traumatic fracture, right? It's contraindicated for that sort of thing because you run the risk of displacing something if there is a true fracture in there like that. But if you're suspicious of a stress fracture, if you're suspicious of a pathological fracture, things like that, the calcaneal squeeze test is probably the most effective way of doing that. Other options would be kind of grouping that type of test with increased pain with weight bearing or an inability to weight bear. That's very common of weight bearing stress fractures, weight bearing pathological fractures, is they're not able to bear weight on that portion of the foot. So you may see them walking in on their toes, something of that nature. The other option is actually using vibration, and this should be true of any fracture in the body, is using a tuning fork against a potential fractured bone should reproduce pain, especially if you can get over the fracture site. Sometimes that can be difficult with the calcaneus because of the depth of some of the tissue. So if we have an intra-articular subtalar fracture, for instance, you may not be able to get a good reaction from vibration test based on where the fracture is within the structure of the bone, right? It's just going to be too deep. You're not going to be able to get in between the calcaneus and the talus in order to stress that tissue. So the vibration test isn't something that you have to rely on unless you can actually get the vibration point over the length of the bone, right? So it works a lot better for things like tibial stress fractures, for fibular fractures, things of that nature, where the bone is completely exposed to you and you kind of use that more consistently there versus with a joint like the subtalar joint that can be so deep and is not easily exposed. Do we have any questions about that? Because that's really the first thing that we should be looking for when we look for heel pain. Yeah, so Deb's asking about therapeutic ultrasound. In theory, it should be able to, but you really have to crank up the frequency to get it. So you don't want to use pulsed ultrasound. You don't want to use 50%. You want to use 100%. And you really got to get it up there. Because typically with therapeutic ultrasound, we're using it. What's the range? 1.0, 1.2, 1.5 hertz. We're going to want to crank that thing up around like 5 hertz in order to make sure we're actually getting true vibration of the tissue in question. But yeah, I mean, that's another thing that you could use to help cluster things together, right? So if you don't have a tuning fork in your office, for instance, but you do have an ultrasound unit, you can try that. I don't have any problems with that idea. The question mark always becomes, again, how deep can that sound wave get into the tissue? Okay. So again, does it make sense not to do this, the calcaneal squeeze test with the idea of an overt fracture? It'd be the same as if you suspected somebody of having a fracture and your decision was to go ahead and, okay. So the next sort of stuff that we have to consider, probably the obvious one, is plantar fasciitis, or at least what we've been described to as plantar fasciitis. Fasciitis in general is actually pretty rare. I think Jim, he probably mentions this on the video. I didn't actually get a chance to watch the videos, but a true fasciitis means that the tissue itself is actually inflamed. The fascial tissue of the body tends to have these inflammatory reactions with things like ankylosing spondylitis, any type of systemic inflammatory condition. The fascial tissue tends to get very much kind of targeted by these conditions, for various reasons that I'm not going to get into right now, but it's going to tend to be bilateral when we have problems like that, right? So it's not going to be a singular thing just in the foot. In one foot, it'll tend to be both feet, and oftentimes it'll be both feet plus the palms of the hands that'll be affected. And there's certain other things that we can ask about when we have to do this, when we're suspicious of this sort of problem. Conjunctivitis, so having problems in and around the tissues of the eyes. It won't be red though, right? So conjunctivitis tends to turn the eyes red, but there will be no redness associated with this, but it'll feel about the same, this very itchy, burny type sensation within the eyes, but we just won't see the same type of reactivity that we would notice with a true conjunctivitis. The other one is actually a urethritis. So this would be kind of the typical, are you having symptoms when you urinate? And again, the urethral tissue is very fascial when it comes down to it. The lining of that has a lot of fascial connectivity to it. So it's very irritable with that sort of thing. So the mnemonic that we've tended to kind of use with that is you can't see, can't pee, and you can't climb a tree because you can't grasp or put your foot on something. So use that how you like. I don't particularly care for it. It just doesn't sound, it just doesn't add up with me very well, but you can use that if you like. But again, these are very consistent with things like ankylosing spondylitis, with things like rheumatoid arthritis, even things like ulcerative colitis. These sort of systemic inflammatory conditions can cause that sort of stuff. Got a question. High success rate when treating plantar fasciosis. Yeah, actually, I have a very high success rate of treating plantar fasciosis. What about anybody else? Anybody else have anything that they go to with the unilateral fasciosis? Let's hear some of our fellows maybe chime in. Matt, you have anything for me? I know you treat this stuff.
Sorry, I was looking at the chat. Do you just mean in like go-to assessments to dictate treatment?
Well, yeah, let's do that first. Let's go down that road first, so that we're actually looking at, how do we first assess this sort of thing. There are a couple of tests that are relatively decent for fasciitis. The windlass test tends to work pretty well. I don't know if Jim mentioned this one, but basically it's kind of a weight-bearing dorsiflexion. So in stance on the one leg, on the affected leg, you lean over the toes, lean the knee over the toes, so you dorsiflex the ankle. That should flatten the foot out as much as you can, and then you lift up the big toe to affect the windlass mechanism. With a fasciitis, true inflammatory condition, that should be positive. It's much more difficult to get a good positive test with a fasciosis, simply because most of the irritability comes after a prolonged period of rest, so period of non-weight bearing. So if you have somebody that's been sitting for 20 minutes in your waiting room and you want to give them a test with it, then you might actually get a positive with it. But oftentimes it may not be as effective. The other option there is, after you lift the toe, is to actually press down on the arch of the foot, right? So if we have the foot here, we get them into that windlass mechanism. So we bring the tibia over the top of the foot here, that should pull the foot up like so. And then we would lift the toe. We can come down on the arch of the foot and try and stress down into it. That actually will tend to sensitize the test a little bit, may give us a better feel for whether or not we have a true fasciosis, because realistically, the only structure we're stressing there is the plantar fascia. So if it does become positive, we're pretty confident at that point that we're dealing with the plantar fascia itself. Okay, now, so Jenna, we'll get to the treatment stuff here in a bit. So just give me a few to kind of go over some of these other things. Unilateral. Doing the windlass non-weight bearing, you're going to get a lot of false negatives. You're just not going to get enough stress on that tissue. It is designed to be done in weight bearing. Yeah. Otherwise, plantar fasciosis and fasciitis, you're just looking at kind of the clustering of symptoms here, right, guys? So the plantar fascia should be coming off the front end of the calcaneus. So most of the pain should be off of the fat pad. So we're actually getting more into where the arch of the foot would be. And you tend to have to, with a fasciitis, the pain should be more superficial. You should be able to palpate it relatively easily, reproduce it with palpation relatively easily. With a fasciosis, you really have to dig in there to get into that tissue. And you may actually have to kind of slacken it off a bit in order to produce that, which would just be by pulling the big toe into flexion. You can actually get a little bit of that, and you could actually invert the heel some. So if you produce inversion of the calcaneus, you may actually be able to get a little deeper palpation with that as well. With a fasciitis, it's going to tend to also get more irritable the more you walk on it. Whereas with a fasciosis, it tends to improve with weight bearing with walking, right? So we tend to notice that. That's also part of the reason why it tends to be more painful first thing in the morning for a fasciosis, is that you're not weight bearing on it, and then you have to get up and move around. But within about 45 minutes to an hour, it's usually calmed down some. So they don't tend to have the same cluster of symptoms. It's usually going to be pretty obvious when it's a fasciitis, because it is, again, irritated tissue that you can't help but put pressure on. Okay, does that make sense? All right. Now, let's get into a little bit of some of the treatment mechanisms that we're going to do. Matt, I know we were just calling you in on this one. So what do you got when you're looking for fascia?
Tell you, man. Yeah.
No.
4.
Is there anything back here?
2 on.
When you come here next?
Me?
Yeah.
What is this?
Monday.
I'm not sure. Who
I'm
this
here
is.
Monday, Wednesday, Thursday. I'll be here a little bit on Tuesday. Are you here Tuesday?
Tuesday to Thursday.
Yeah.
What time Tuesday next week?
Let me check.
I can't mute anybody, so I'm kind of at a loss here. If you're not muted, let's mute ourselves here.
What's your name?
Kristen.
I'll be here when you're here.
Okay.
Yeah.
I'll bring a book that should be built to layout.
Sweet. Yeah, that's cool.
Okay.
Seriously, let's mute ourselves here.
Yeah.
All right, try and go
We'll be
ahead,
okay now.
Okay.
Yeah, no problem.
Well, then why did you tell it?
For you to, never mind.
That's all back.
Yeah, exactly.
Where is Bender when I need him? We are recording, yes.
Okay, so I guess I would look at
Okay.
mechanisms that would lead to overstressing the plantar fascia. So whether that's I primarily look at the subtalar joints. I think that's kind of like the foundation for setting the foot down and how the rest of the foot compensates, especially with gait. So I will probably look at more of the hind foot and midfoot for potential mechanisms to create that mechanical stress.
You guys are glad to do it. I mean, I'm very happy with how we're doing. But, we come in.
Yeah, and that's going to be kind of our primary method here. Dear God.
I mean, I think about when I first came here.
Sorry, this one.
Let's get that forward in. Yeah.
Yeah, order that.
Great.
Start yelling to
Sure.
start
Got
yelling
him. There we
to-
go. All right. All righty. So basically what Matt's saying is the plantar fascia is designed to help support the longitudinal arch, right? So it's designed to help keep the arch intact as we come over the top of the foot so things don't fall apart. So essentially anything that is going to potentially over flatten that portion of the foot is going to be something that's going to affect the plantar fascia and could eventually lead to a progressive degenerative mechanism to what, where we'll actually develop some pain. So things like forced calcaneal eversion, right? So if the foot is stuck or subluxed into an everted position, we'll constantly be putting excessive pressure on that. Something that'll actually take the metatarsal heads away from the calcaneus will also do that sort of thing. So a dorsal subluxation of one of the first metatarsal, second metatarsal, any of those sort of things will also do it. A dropped cuboid could do it in respect to the lateral components of the plantar fascia, things of that nature. We could have anything from any of the cuneiforms, the talus, excuse me, not the talus, the navicular on the talus, all these sort of things will tend to over flatten the foot. Now, we could also have neuromuscular components here that can cause problems, right? So anything that would affect the posterior tibialis will also essentially tend to diminish the muscular recruitment that is effective in helping to support the arch. Now, when we look at research, it tends to suggest that the musculature, the amount of muscle recruitment needed to support the arch is relatively minimal, right? Most of this is done via the architectural structure, right? So the makeup of the joint components, the actual interconnections between, say, the metatarsals and the tarsals, or the navicular and the talus and the subtalar joint and all these sort of things. These are the architectural standards, right? And then we have the supporting mechanisms, which is the joint capsules, the ligaments, and the plantar fascia. So without needing too much muscular support, these things are very effective at helping to protect the longitudinal arch of the foot. The problem is when we have minimal muscular effort contributing to stability there, it tends to mean if we lose that, then we're going to be in trouble, right? Because now all we have are these passive structures. So being able to adapt the position of the foot, if we have some sort of delay in recruitment, which can happen with local issues, right? So we'll have poor reflexive feedback to things like the peroneals, to things like the posterior tib, the anterior tib, all the various foot and ankle musculature. If there is a delay in the signaling to these muscles to turn on, right, we could end up putting additional stress on these inert structures. That could be something as simple as a segmental facilitation, or something as significant as a radiculopathy, right? So, and everything in between. AXT problems can certainly do this thing to us, where we start to develop breakdown of the end organ or the end structures, which could include things like the plantar fascia, but we would tend to have more consistency with some of the other symptoms. We would tend to have fatigable weakness, for instance, associated with an AXT problem, and it should be in the distribution of a particular nerve, right? So whether that means it's a peripheral mechanism, which probably indicates a double crush syndrome, or whether it indicates some sort of spinal lesion, right? But either way, any of these sort of things can lead to excessive wear on the inert structures on the plantar surface of the foot. So it's our job to essentially figure out where that comes from. And the methods are pretty simple, guys. It's pretty much the same as what we were doing in the spinal segments. Is we stress those tissues as best we need to, right? So we look at, for local lesions, we'll look at mobility, right? We're going to do mobility testing, assuming that our target is going to be a hypomobility that is creating a hypermobility someplace either up or down the chain. So the most common one that you're going to see for a fasciosis locally is going to be some sort of subtalar lesion, right? Some sort of restriction of subtalar joint mobility that's then affecting the midfoot and the forefoot. Okay, so that's the first thing you tend to look for. You can certainly have it with issues around the talocrural joint, right? So where we're actually flattening that talonavicular arch, that talonavicular joint, dropping the navicular plantarly in order to make up for a loss of ankle dorsiflexion. Those sort of things happen quite a bit. That again will put a lot of stress on the plantar structures of the foot. So that's essentially how we're going to look for local lesions, whether that belongs in the subtalar joint or if it's more midfoot or forefoot lesion. All right. So We can also use muscle testing in this regard. Muscle testing looking for reflex inhibition, right? So we should see if we have, say, a subtalar joint lesion that would be affecting the plantar fascia, we would see reflexive weakness of the muscles that cross the subtalar joint, right? That produce inversion and eversion. So posterior tib and then the peroneals. Now, again, reflex inhibition is going to be more of a consistent braking weakness when we're testing for it, right? So that's the one where we put the foot into a particular position, we say hold it there, they hold for a brief second, and then it just gives out on us. We retest it a few times, and it gives us the same braking result. That's very common. And you should be able to look at that and test both directions, inversion and eversion, and have both come up positive. Beyond that, because both of those are going to be the inverters, right? So the posterior tib is going to be L4, L5, very commonly. The everters are going to be more L5, S1. So you can make the argument there that both of those could be L5, right? So you would need to test another L5 muscle that doesn't have the same peripheral innervation, right? So you'd have to move away from this in order to test, say, hip abduction, right? Everybody staying with me so far on all that? Okay. Now, if we're looking at a segmental issue, we're going to have one of two possibilities here. We're going to either have a radiculopathy or we're going to have a segmental facilitation, right? So the idea would be trying to differentiate between the two different types of weakness, right? So fatigable weakness for radiculopathy would have to be presenting, and it would have to present throughout the segment. Again, you go back and test another L5 muscle, potentially looking at potentially hip abduction, maybe hamstrings, something of that nature, in order to determine if there's also fatigable weakness throughout that segmental distribution. Otherwise, you're going to be testing for velocity dependence, right? And this is our method of really diagnosing. In my opinion, the most effective method of diagnosing a segmental facilitation is via velocity dependent muscle testing. So again, you would back off of the strength testing and then just test the muscle resistance quickly. And the weakness should significantly worsen if it's a segmental facilitation. So again, this just alters our target. What are we going to treat, right? Because that should always be the question in the back of your minds as you're going through these sort of tests and measures is what am I going to do to make this person better, right? So if you find reflexive weakness, you're probably going to treat something that's local, right? You're going to look at the subtalar joint, you're going to look at the ankle, you're going to look at the intertarsal joints, all that sort of stuff. If you find segmental issues, you're going to be going up and doing a full lumbar examination, biomechanical examination to say, all right, now we've got a segmental facilitation that's presenting at L5. Okay, what's the problem with L5? Is it unstable? Is it hypermobile? Is it inflamed? You know, what is the problem here that's causing the facilitatory effect? Same thing with radiculopathy, right? We're going to go back and we're going to test that out, see what the problem is there. Are we treating an old disc lesion? Are we treating a guillotine effect? Are we treating, you know, any number of other things that could cause compression or tension, right? So tension on the spinal nerve that would actually affect conduction. So it could be an inflammatory issue. These things tend to be more chronic if they're coming in for a true radiculopathy versus something that's coming in with because otherwise you tend to think they'd be coming in for a back issue, right? Sciatica, that sort of stuff, if it was more acute. Guillotine effect. Oh, it's basically where the foramina has kind of come down on the nerve to compress it, right? So it looks like a guillotine, the old medieval chop your head off machine. I think Matt's got one in his clinic. People that don't pay attention. Yeah, see, told you. So it's just another mechanism by which we get compression on the nerve. It would tend to indicate probably a very significant extension, hypermobility or instability, or potentially some sort of pars defect where you've actually had the thing slide forward or it's kind of come across like this as opposed to coming down. But those things do happen occasionally. Okay. What else do we got? So what else do you think, Matt? You got anything else that you want to mention as far as what you're going to look for? Common profiles that you see?
No, I would probably say I always see a contributing local mechanical stressor almost always. And then most commonly I'll find probably a hip limitation as well, especially in the extension that can contribute to over flattening of the foot. Those are my first, if I'm looking for mechanical stressors, those are my first go-tos, is the subtalar joint and probably the midfoot, and then the hip for contributors. Obviously, like you mentioned, doing different weakness testing to see if it's facilitated or to see if it's more of a reflexive, strictly reflexive inhibition helps to make your treatment a little more organized.
Yeah, I totally agree. I mean, the first thing I look for when I have somebody come in with a plantar fasciosis, or at least what I'm, considering as a plantar fasciosis, because I think we've all seen the prescription from the physician that comes in that says plantar fasciitis, and the pain's not even on the plantar side of the foot. So again, you have to make this determination for yourself as you're examining the patient. But first place I'm looking is that subtalar joint, because that's the easy thing to fix, right? And we'll learn how to treat those things here next month when we come out to do these peripheral classes. But that's so much easier than having to deal with how am I going to fix a segmental facilitation that's affecting this sort of thing. It's such a can of worms. So you really, if you have something local, that's going to be your first target, right? So the other thing that goes along with that is if you have a segmental facilitation, but there is also a local dysfunction, you have to fix the local dysfunction because it will tend to drown out that facilitation to begin with. Essentially, the local problems, the reflex inhibition that will be present due to the local joint pathology, will overwhelm the segmental components coming down. So when we go to do our strength testing, you won't even get to velocity dependent testing, because as soon as you put pressure on it, it's going to start giving out. You're going to get that reflex inhibition before you're able to do something quickly to test for strength issues there. So certainly local is where you really want to go. Number one, it's going to be easier for you to treat over the short and long term. And number two, it's going to affect any potential diagnosis that you're going to have for something that is more proximal. Right, so Deb was asking, since a radic is segmental, can you have fatigable and velocity dependent weakness? That's a good question. I don't know. I bet you probably can over time. The difference is you'll never be able to test for velocity dependent weakness, because the muscle will start to fatigue so much so quickly that you'll never actually get to that point. It'll be too weak for you to test for velocity dependence. If you've ever actually tested a muscle and you find fatigable weakness, typically you test it the first time and you get a little resistance and it starts to break. And then by the time you get to the second test, it's barely being able to hold itself together. So you're not really going to get to the point where you're able to test for velocity dependence. One of the more common reasons for segmental facilitation, oh yeah, it's too bad if you're only hearing a few words. Is anybody else having that issue? Is it everybody else is hearing me at least? Okay, good. So one of the most common reasons that you can have a segmental facilitation is an old disc lesion, right? Something that never got treated, or didn't get completely treated, or it was too big for it to be completely treated. But essentially, that can give us that kind of abnormal nociceptive feedback that's going to eventually facilitate the segment, right? So you could have had an overlying radiculopathy to begin with. If it was treated properly, whether by conservative means or by surgical means, an old disc lesion is one of those reasons that you could develop a facilitation. Now, I don't expect you to be able to find radiculopathy and segmental facilitation all at once. That's not likely to happen, because essentially when you think about it, radiculopathy diminishes all of the neurologic output. right, and input. So sensation, strength, and reflexes all go down. But a facilitation essentially winds everything up, right? So we have brisk reflexes, we have hyperesthesia, increased sensation to pain. And actually, when you think about what happens with strength testing with this, is it actually ends up being an increase in muscle tone, right? So the resting tone has increased, even though the muscle strength actually diminishes. The strength deficit that we get with segmental facilitation is really more due to a reflex mechanism than it is a diminishment of the actual muscle's ability to contract, right? So the thought process that we have with this is that the GTO, right? The GTO senses the amount of tension that goes across the the musculo-tendinous unit, right? So it's there to sense how much tension is on this structure. So with the facilitation, because the intrafusal fibers, right, the gamma motor fibers have wound themselves so tight, they've pulled too tight because they're essentially getting triggered more often. The GTO becomes triggered more quickly with speed dependence, right? And so it becomes an inhibitory stimulus to the muscle. It just says, turn it off or something's gonna snap. So the idea here is that it's not actually a decrease in strength, it's an increase in tone that increases the amount of tension across that. So when you're thinking facilitation, with obvious connotations here with the word we're using, we're talking about increasing these things, as opposed to with radiculopathy, we're thinking about decreasing these things. So realistically, even though an old radiculopathy can eventually progress into a facilitation, I would not expect you to have both at the same time. And even if you did, I don't think there's any way for us to test for it. We all good there? Okay. So again, one of the most common things that I see, and this, I doubt Jim mentions this, but because this is one of the things that I've kind of come up with in my time in the clinic, is that there will be people that will come into the clinic that very much present similar to a fasciosis, right? So they come in, they say, my foot hurts me, my heel hurts me, it's worse when I get up from walking, it's worse first thing in the morning, and then it improves if I'm up on my feet for a while, right? And so you're starting to think, well, okay, this looks like a plantar fasciosis based on the location, based on the behavior, and you just don't know at that point what causes it. But there is a pathology of the intrinsics of the foot that will act very similar, and it's not the actual plantar fascia that's actually painful, right? So this is more, the abductor hallucis. This is more the flexor digitorum brevis, flexor hallucis brevis, these sort of muscles, and it's more of an insertional tendinitis that will actually be caused by this over flattening of the foot. Now, why does that matter is that with these sort of things, cross friction massage can actually be beneficial, right? Whereas with a plantar fasciosis, you're not real likely to get in deep enough to do a true cross friction massage on this structure. It's just not going to benefit you as much as it would for an insertional tendinitis once the initial irritation has died down. And again, tendinitis, tendinosis, these are not interchangeable words. You have to be certain that you're comfortable with the phase of healing that these structures are in. Something that is a tendinitis where it is actively inflamed, it is contraindicated to do cross friction massage. It's not a good idea. All it's going to end up doing is making things worse. But a tendinosis, something that is beyond that initial inflammatory phase. And again, the initial inflammatory phase is usually somewhere in the 5 to 10 day range. It might, in some cases, stretch out as far as 2 weeks. But once you're past that time frame and you're into more of the substrate phase of healing, cross friction massage is one of the best things that we can do for soft tissue lesions. And we'll go over a lot of methods of doing that specifically for the peripheral joints during class this time around. Kind of the parameters that we'll use for that sort of stuff and how to position things to get on the appropriate tissue. There's some really unique things that we can do with the Achilles, with the patellar tendon, with the biceps tendon, with the with the common extensor tendon, all these sort of things that do tend to help make them more effective. So again, not going to get too much into that stuff right now because we got to have something that we can still talk about during class when we get there. But we'll get into that stuff as well. So most of the same mechanisms of injury there are going to be kind of similar, right? So we're still going to be looking for things that are going to overstress the medial side of the foot, because essentially all these structures are going to attach to that medial calcaneal tubercle. So the pain is going to be a little more medial than where the typical insertion of the plantar fascia is going to be. That tends to come more off the exact front, the anterior calcaneal tubercle, and actually moving more laterally as we get to the lateral components. You okay with that so far? Okay. The other thing that we can get that will oftentimes mimic a plantar fasciosis is an actual, it's a repetitive impact injury to the medial calcaneal tubercle. Again, I doubt Jim goes into this, but it's in typical gait, in typical striding, typical stance, our body weight should come down on the lateral aspect of the posterior edge of the calcaneus, right? So if we're looking at this as my foot, and this is the lateral side of my foot, just like it is for my hand, we're really supposed to heel strike kind of right in this area, right? So what will tend to happen is if we get an internal rotation of the leg, we'll actually start to heel strike on this medial calcaneal tubercle. And it is just not designed for that sort of stress, at least not that sort of consistent repetitive stress. So what can cause that sort of thing? The most common cause for that sort of pain is actually a Eufer lesion, right? So the loss of strength of the short hip external rotators will allow that foot and the essentially all the way down from the hip to internally rotate. And so our point of contact becomes more medial. So again, what will happen with this is it won't be consistent with the same sort of illness script, right? So the pain will be more on heel strike as opposed to toe off. It won't be the same as far as it's more consistent after a period of non-weight bearing. And it will tend to actually worsen the more you're on the foot, right? So the more you're walking around, the more impact you have on that, the more irritable it's going to become. So again, not gonna match up with the things that we see with a fasciosis or a fasciitis based on where in the stride the pain actually starts to exhibit itself, right? Because with a fasciitis, it may be painful as you rock over the heel, but it's actually going to be most painful as you tend to get to the totally flattened out portion just before you lift the heel, go into that windlass mechanism. So again, it's not going to match up as well, but the treatment then becomes we need to fix the Eufer, right? As opposed to worrying about local lesions around the foot and the ankle or segmental lesions up from the spine. All right, you got a question here. Thoughts on calcaneal bone spur? Yeah, I mean, a bone spur certainly could be the cause of heel pain. Essentially, it's just going to, depending on where it is and what structure it's going to impact, you could have it affect either the fat pad or the plantar fascia, depending on, essentially which structure it's kind of aimed at. The problem here is there's not a whole hell of a lot we can really do about this sort of thing, right? So bone spurs form as a result of the structure they're attaching to. So in this case, it'd be the aponeurosis attaching to the calcaneus starts to peel the periosteum away from the bone. So we get this, here's the interaction between these two, this being the periosteum. What tends to happen is it starts to peel that away. And this interstitial space now in between where the aponeurosis attached and the actual cortical bone fills in with more cortical bone, right? And so as it continues to peel that away, we get this hyperostosis that builds up, and that's where the spur actually comes from. So essentially, the best thing that we can do for it is figure out what the cause of that increased stress was, right? So why did this start to peel away? This could be a degenerative thing. So that'd be consistent with a local lesion that's just increasing potential stress on that tissue. So yeah, we could go in and say fix a subtalar joint lesion, but will that be enough to remove the stress from where that bone spur is actually affecting the surrounding tissue? You know, you kind of got to shrug at that and say, like, we can do this stuff, but there's no guarantee that this is going to actually affect the change that we want. And that's just because, you know, bone spurs are a structural change, right? There's something that's going to be there, barring going in surgically and removing them. So, yeah, I do believe that you could have spurs that will cause heel pain, but you got to look at it from a perspective of what caused the spur, right? Something had to have affected that change to begin with. Does that answer your question? Hopefully.
Yeah, thank you.
Okay, good. Any other questions so far on what we're talking about? Not currently. All right, good. All righty. Let's see. I thought I saw something about, yeah, Anna had a question. Sorry, Anna, I must have missed that for a second. So let me go back and take a look at this. Patient that came in initially for Achilles tendinopathy, resolved that. Ankle sprain caused instability, resolved that, good. Presenting with medial and lateral calcaneal pain. Being as chronic plantar fasciitis. Okay, well, this is good. So let's take a look at this. So Achilles tendinopathy, got that taken care of. Anna, how did you treat that?
So can you hear me?
Yep.
Cool. So first as it came in, so background, he's mid 40s, super duper active, like 6'3" guy, loves to play tennis, jogs 3 to 4 times a week, does regular lifting as well. So very active, very competitive. Started with some cross friction. He had a notable bump at the insertion. So started with gentle stretching, some neuromuscular re-ed for foot intrinsics, and some strengthening. So that resolved actually really quickly.
Good.
Which was nice.
And then the instability, where were you finding the instability?
So when I did his anterior drawer, it was like, whoop, like that classic, like had multiple ankle sprains and so it was just like, it went. So did that, and he just like any kind of did some PNF like diagonals with his ankle, and he could not maintain a smooth arc of motion.
Okay.
So added in some more, like I already had him doing 3-way hip on an AirX. So added a little bit more. I think I added some specific, like more PNF, added some single leg TRX squats and some lateral lowers. And I figured out that he was utilizing some major knee strategy with any kind of squatting motion,
okay,
but only on that side. Like his other side, hip strategy is beautiful. But he's also had, flat feet his entire life.
Okay. Well, and let's consider that for a second. So flat feet his entire life, probably not an issue, right? Because if it was, he'd had pain the whole time, right? So something has to have changed, right? But if you consider people with flat feet, there's one thing that you want to expect out of them in general. They should be very mobile, right? They should have a very mobile body type. Because essentially if they don't, then the flat foot is an outlier, right? So they tend to have, some genu recurvatum, they tend to have very mobile hips, they tend to have very mobile shoulders, all these sort of things. That's just the nature of how people are put together. You don't have these random, like, oh, I have a stiff body type, but my foot is flat. That's not normal. Something would have had to have changed for that to occur. So that's just, person's particular body type, right? And then you have to consider the environment that they're in, right? So somebody that is on their feet a lot, that has flat feet or acquired flat feet, and especially, they're not going to do well on real hard surfaces, right? They're not going to do well standing on a concrete surface doing, rotational motions, like with a cashier, right? Who's grabbing stuff and swinging things across a scanner all day, right? Because they're standing all day. Their feet are rocking into inversion, eversion constantly as they twist over the top of them. People with flat feet that don't have a very mobile body type are going to really suffer with those sort of things, right? So got to consider some of that sort of stuff. As far as his chronic fasciitis, are there particular things that he mentions that are bothersome to it?
Not so much. He, first thing in the morning, but not really like first step so much, just like it's stiff first thing in the morning. Like he says, it feels stiff in the bottom of his foot. Right now, he's like, well, the back of my heel doesn't hurt anymore. The front of my ankle doesn't hurt anymore. But when he's playing tennis or running, he feels the pain on either side of his calcaneus.
Okay, more toward the bottom of the calcaneus or up toward the subtalar joint?
More towards the bottom, like right at the top of the fat pad.
Okay. Well, there's a few things that could be going on with this guy, right? So he's had prior Achilles issues. He's had prior instability issues or, laxity issues around the ankle. And now he's got, what he's considering chronic fasciitis, which I assume means he's had this before. So the options here are, there is some underlying problem that he has that continues to put pressure on this foot. Now, the three things that you've mentioned here could all be caused by potentially one problem right at the ankle, and that would be a subluxed talus would cause pretty much all three of these things. Essentially, when you look at somebody that may have had previous ankle sprains, one thing that can happen is the ankle sitting in that mortise, as they roll the ankle, you get this sort of slip where it'll internally rotate or medially rotate and come forward, depending on the position of the foot when it happens, whether it's plantar flexed or neutral. So a subluxation there will cause all of these issues. It'll cause an Achilles tendinopathy very easily, and can very easily start to attenuate some of the structures around the, particularly the lateral side of the foot, but could cause the same sort of idea for an anterior drawer on the medial side of the foot. Right. So when you're doing the drawer test and you're pushing that tibia and basically the mortise posteriorly to produce that anterior drawer, you'll tend to get a rotation with it if it's more medial or lateral. But a talus that has come forward will put constant pressure on the ATFL and the anterior band of the deltoid. So those will tend to deteriorate. They'll tend to become more lax. And then as far as where his body weight pressure is over the top of the foot and on the heel pad, essentially, his feedback mechanisms to the muscles around the lower leg, for instance, the peroneus, posterior tib, the things that are supposed to help correct these side to side movements, is going to be really bad, right? So if he has a subluxed talus, the joint receptors, the mechanical receptors within the joint capsule of the talocrural joint are going to be jumbled all to hell. So he's not going to get good feedback from the ankle mechanical receptors to trigger these muscles to turn on at their proper time. So you'll start seeing this increased sway, this increased, this really poor ankle strategy, all that sort of stuff will tend to really be demonstrated, especially in single leg stuff like what you were telling us about. So that could very easily be the problem. The other option would be an unstable ankle mortise, which would be where the actual inferior tib fib joint has splayed apart. I'll show you guys how to treat that in this next class. It's probably one of the more common instabilities that you find in the foot and the ankle, and probably the least commonly detected. So it's there quite a bit, but people just don't find it because they don't know to bother to look for it. But that's going to throw all kinds of things off kilter, right? It's going to end up fixating when you're in weight bearing. So essentially what will happen is this will lock into this position. It won't allow the foot to move very well when in weight bearing. So it'll act very similar to a subluxed talus, but essentially it's a fixated instability. But then it'll end up causing the exact same problems, right? So you don't get good ankle dorsiflexion. That'll affect the Achilles. And then you'll get the, what was the other thing I was thinking of? The instability, same sort of idea, right? So you won't have good ability of the mortise to kind of control these things. So either one of those two things would be my first suspicion. So there should be there is some stuff in the curriculum about the subluxation and the mortise instability. It's in some of the didactic material, without having to go into too much of the specifics of how to treat these things and test for these things. But essentially, if you have a talus that cannot glide posteriorly underneath the ankle mortise, and and non-weight bearing especially, and it feels pathomechanical, it's a subluxed talus, and that's going to be the big issue. So doing a traction manipulation to get that thing to reset is the best method there. Now, the mortise instability, you have to tape this thing up and do all kinds of things. We'll get into it during class because it's a bit more involved. But that'd be the first place I'd look. I'd look for a subluxed talus on this thing. I mean, it could be a couple of other things, but with the Achilles tendinopathy, especially if there was no specific increase in activity for this guy, that'd be the first thing I'd look for. I'm guessing Matt would probably agree with me on that.
Yeah, his Achilles pain started like when he got at it. He wore a brace for 2 weeks after his ankle sprain. So
yeah. So, well, and in that case, you could look at it potentially from the other direction as well, right? So, and the only thing, one of the differentials for a subluxed talus is a capsular restriction, right? But they don't look alike because a capsular restriction will actually restrict plantar flexion more than dorsiflexion. Doesn't mean there's still not a restriction of dorsiflexion though, right?
Yeah.
So what you'd have to do is essentially go in and look at his active range of motion. Does the plantar flexion match left to right? And if it matches left to right, and then your end feel with your posterior glide of the talocrural joint shows a pathomechanical end feel, then the distraction manipulation is the best. If the plantar flexion is different and it's significantly limited on the effective leg, you probably have a capsular lesion and you don't want to manipulate it.
gotcha.
Right. And then you're dealing with just consistent mobilization to restore ankle dorsiflexion.
Cool.
Okay. That'd be what I'd look for on that. I'm missing things down here on the end of the message chat. Here, give me 1 second.
It's okay. Thanks for
Similar
troubleshooting.
things, yeah. Similar things with Sever's disease. Sever's disease, I don't tend to get too worried about because it's a self-limiting condition. You know, very, very similar to Osgood-Schlatter, right? So those things will tend to resolve on their own eventually. You can manage some of the pain and discomfort, but you know, that's mostly modality-based stuff. Flat feet contribute to tight external rotators, and then tight hip external rotators also contribute to the feet to flatten more. Well, tight external rotators. If you had tight external rotators, in theory, that would actually elevate the arch of the foot, right? Because essentially, if we're looking at our foot here and we externally rotate, what happens is the foot goes into supination, right? So you wouldn't expect it to actually flatten the foot more, but would flat feet contribute to tight external rotators? I think they would present as being tight, because a flat foot, right, like this, is going to cause internal rotation of the tibia, internal rotation of the femur. So essentially, as the straighter trochanter moves away from its insertion point, they're going to feel very tight, but they may not actually be tight. It's just one of those things because they're actually increasing the tension as the two insertion points move apart. So no, I wouldn't look at it from that perspective. Do you have something specific, Isaac, that you were considering there? Body type, okay. Yeah, I mean, body type stuff, again, it should all match up, right? I mean, this is the problem with things like ballet dancing, right? Because they need to have very rigid feet to support themselves up on point, but they also have to be extremely flexible in order to produce releve and to get this hip external rotation, the amount of extension they need through the lumbar spine. All those things have to be very mobile, but you know, unfortunately, that dichotomy is very rare. So body type just has to match up with the rest of the body. So if they've got flat feet, they should be mobile, and it's not going to be a problem. They should be mobile pretty much everywhere else. We'll see, I'm sure we'll see some people that are kind of similar to that in class where we're looking at, well, yes, this person looks like they have a stiff body type, but here's a portion of the body that actually is very mobile. that's probably an acquired hypermobility as opposed to one that they've always had. All right. Hopefully this was still useful. I know I probably repeated some of the things Jim talks about in his video. Again, I didn't get a chance to view it, but hopefully some of these other things were at least useful. We'll continue on. There's some more stuff. I think in the second video, Jim gets with the heel stuff. So we can continue on with that next week as well. All right. Everybody have a good week. We'll talk to you in a week.
Yeah, thanks.
Yep. See ya.
Thanks, Eric.